Welcome. My name is Amy Bellflower Thomas. I'm our Senior Director for Research and Evaluation here at PHAB. And we're really excited to have you join us today to talk about some of our data. So this presentation is about from data to impact. It's about our evaluation results and how researchers can engage with PHAB data. I have with me colleagues Britt Lane with PHAB, as well as Rachel Van Vliet and Catherine Gelfand from NORC at the University of Chicago, who work with us very closely on many of our data projects. And want to acknowledge Sarah Nasrallah Fournier as well, who's helping us coordinate the session today. This is the first of kind of this look at our data. Last year, if you attended a couple of sessions we had on our impact evaluations, on COVID-19, you may have seen that one, and then we had a small health departments one. This is an attempt to share the latest impact evaluation results we've had. So you can see here on the agenda, we'll have NORC presenting on both of those. The first of which is strengthening emergency preparedness through accreditation, and the second on the SRI public health accreditation. And then Britt's gonna end us talking a little bit about if you would like to work with the data a little bit more. All of our data is open source and available, but you do have to request it. So they will go through a little bit of what kind of data we have, how to request it, and things like that, and where to find that. And then we'll close out. So it should be a pretty quick hour. Do want to say that we are using the Q&A function. So if you have any questions as we go along, please drop that in the Q&A, and we will get that answered as soon as we can. If you don't have time to answer a question or you have a question after, we'll be throwing in an email address in the chat in a little bit that you can ask those questions there. Next slide. So what do we call our impact evaluation? So we've really been lucky over the past couple of years through our contract with CDC, our cooperative agreement. We've been able to invest some resources into really doing some enhanced evaluation on the impact of accreditation. So as Britt will tell you a little bit at the end, we do a lot of internal evaluation at PHAB. We have a lot of data. We look at a lot of that data, but honestly, we have more data than we can even analyze. And also, there are sometimes some things that we learn from our data that we want to ask some more questions on and get beyond our data. And that's really what these impact evaluations are all about. So this is the second year, or in the third year right now. This is the presentation of the second year of these evaluations. You can see the period of performance was last winter and spring. The two topics, and again, want to thank CDC for their support of these impact evaluations over the years. So just to show you a little bit, we've kind of taken an iterative approach. We do have a logic model, and we do have some research questions that were developed in 2021 by a group of researchers, internal and external to PHAB. And from those, we really wanted to get to kind of, if you look at a logic model, the right side of that logic model, or to the more longer term outcomes now that PHAB's been around for quite a while. And so a couple of things we first looked at. So again, these go back to fiscal year 24, and you can see we did two evaluations that year. One was a quantitative study about COVID outcomes. So we're really interested at PHAB, of course, in seeing the impact of accreditation in community. So is accreditation as a process, is that driving better population health outcomes? That's really hard to do. There's not great research out there about public health infrastructure and accreditation, and even what outcomes may be associated, or we can even predict. But luckily, COVID gave us kind of a natural experiment in that way. And so we conducted that evaluation in fiscal year 24. I'll talk about in a little bit. But from that, there were kind of some limitations, which I'll talk about in a little bit. And one of those was, of course, that initial study was an association study. And so we wanted to know kind of more about the causation. And so that's why we worked with NORC last year to do more of a qualitative study on those contributors. And then you can see on the right-hand side of the slide, we also hear a lot from health departments, especially decision makers in counties and jurisdictions, about what's the return on investment for accreditation. And that's a really tough one too. There's not a lot of research on that about well, what plays into that and things like that. And also we know in public health that not everything is a monetary return on investment for public health. Kind of wellness and saving lives is also really important. So we started a case study specifically in Ohio. Ohio is, again, another national experiment where they have legislation where all local health departments are required to be PHAB accredited. So we did a pretty intense study, or the Health Policy Institute of Ohio did a pretty intense study in Ohio, and they started to look at SROI a little bit, but we certainly wanted to take that to the next level and look beyond Ohio. And so again, that's why we worked with NORC last year on more of a qualitative look at SROI inputs and outputs. And I'll just note at the bottom, in fiscal year 24, we had one other evaluation. I say it's a one-off because it was an evaluation of our new version 2022 and pathways processes. We really wanted to make sure that those two processes were being responsive to the needs of small and rural health departments. And so that study was done, but there's been no follow-up on that this past year. Next. So I'll just briefly talk about those two fiscal year 24 studies so you know how they set up for our presentations by NORC today. But again, looking at social return on investment, which they'll define for you if you're not aware of, the Ohio evaluation looked into this a little bit and found that mostly fees and staff time were the real big contributors to the cost of accreditation, not surprising. But what they also said is that maybe, looking at this is a little premature, that there's more time needed to think about factors beyond the scope of public health system performance that can affect both ROI and population health outcomes. From that, we really wanted to get ready for a time when we could do that and get a better idea about what those inputs and outputs should be. Next slide. And then the follow-up from the COVID-19 study. So we're really excited. This is one of those things where you work with a research team early on and you're just like crossing your fingers that the data will play out the way you hope. And PHAB was really excited to see that evaluation did show that communities with an accredited public health department had lower death rates from and higher full vaccination rates for COVID-19. So a direct association between accreditation status and some population health outcomes. However, there were a number of limitations with that study, the biggest being the lack of a causal relationship. And we at PHAB have looked into emergency preparedness and we had some ideas from some of our evaluation data about some of the causes that we were able to share with NORC to kind of inform their study. So this was really a culmination of getting at those causes. And I will say, as far as exploring other community health outcomes, I'm really excited to say that will be a focus of our main study this fiscal year that we've just started. So with that, that's kind of my setup for the two presentations by NORC. So at this point, I'd like to turn it over to Rachel Van Fleet and remind you if you have any questions as we go through to throw those in the Q&A. All right, Rachel.
Thanks so much, Amy, and good afternoon, everyone. My name is Rachel Van Vliet, and I'm a research scientist in the Public Health Department at NORC at the University of Chicago. And I'm excited to share with you all about strengthening emergency preparedness through accreditation and our lessons learned from local health departments' COVID-19 response. Just briefly, the authors have no conflicts of interest to disclose, and this work was supported by the Public Health Accreditation Board through funding from CDC. So just a brief agenda for my set of slides, a little bit more introduction and context for this specific study to start, and then I'll share our methods, results, and discuss some implications. So by means of introduction, a little bit more background about PHAB in case you are less familiar. PHAB oversees the National Public Health Accreditation Program, and the accreditation program assesses and recognizes health departments' performance against a set of national standards. So as of August of this year, there are 40 state health departments, 406 local health departments, and 8 tribal health departments that have been accredited. And the Foundational Public Health Services Framework defines the public health capabilities and programs expected of health departments, and PHAB's standards and measures for accreditation align with this framework. So you can see here the foundational public health capabilities, which are similar to PHAB's 10 domains. And the public health emergency preparedness capabilities ensure that health departments are ready to respond to disasters, disease outbreaks, and other emergencies. So in our slides about the results from this study, we'll overview the foundational capabilities that emerged as the most influential for the COVID-19 response among local health departments. And the COVID-19 pandemic specifically exposed significant variation in local health departments' ability to respond, driven by infrastructure, resources, and political context. And Amy mentioned the recently published a quantitative study that showed that counties with accredited local health departments had higher COVID-19 vaccination rates and lower COVID mortality rates compared to counties without an accredited local health department. So to build on that work, this qualitative study aimed to understand the underlying reasons why accreditation may improve emergency preparedness and response, ultimately with the goal of helping PHAB communicate about how accreditation can support emergency preparedness and inform PHAB's efforts to update standards, measures, policies, and practices for accreditation and reaccreditation. So to achieve our study goal, as I just mentioned, our research question really was, what are the underlying reasons why accreditation improves emergency preparedness and response for local health departments? So to answer these questions, we developed separate, tailored, semi-structured interview protocols for accredited and reaccredited local health departments. Both protocols asked about how various aspects of accreditation supported their health department's COVID-19 response. And the interview protocol for the reaccredited local health departments included additional questions about specific aspects of the reaccreditation process and their influence on the COVID-19 response. To identify the health departments to participate, PHAB compiled a list of accredited and reaccredited health departments, noting specific department characteristics such as jurisdiction, geography, budget, population, staff size. And we limited the focus of the study to local health departments, specifically to align with the population included in the prior study on COVID-19 outcomes. And we focused on local health departments accredited in 2018 to 2020 or reaccredited in 2019 to 2020 before the COVID-19 pandemic. And then to recruit for the interviews, PHAB sent initial invite emails, and then NORC sent follow-up email communications. And then in March and April of this year, we conducted semi-structured virtual interviews with 16 local health departments, so 9 accredited and 7 reaccredited. We spoke with their accreditation coordinators, health department directors, and other health department staff. And then following data collection, we conducted a rapid thematic analysis of the interview data using a deductive coding approach to identify key themes within and across the foundational capabilities. So what did we learn? So the first aspect of accreditation we explored was community partnership development, which encourages service and resource sharing across public health departments, organizations, and community members to tackle health challenges together. All accredited and reaccredited local health departments emphasized the critical role that partners played in the COVID-19 response. The local health departments partnered with fire departments, hospitals, healthcare companies, labs, schools and universities, nonprofits, faith-based organizations and businesses, just to name a few. Local health departments relied on hospital systems for surveillance data. They worked with faith-based organizations and schools to host vaccine clinics. And partners helped the local health departments mobilize resources quickly by setting up facilities for isolation and quarantine and offering transportation to vaccine clinics. Some local health departments also looked to community partners to help fill temporary staffing positions during the response. And the community partners really helped build trust with community members for the health departments. All health departments are also required to develop a community health assessment and community health improvement plan as part of accreditation, and they're encouraged to collaborate with local partners and community members in this process. So the local health departments cited the community health assessment development process and specifically those partnerships as key facilitators for their COVID-19 response. And here's a quote from an accredited local health department that said, the accreditation process really caused us to sit down to identify the intentional partnerships and the role and the purpose they played in the work that we did. And then when it came time to move forward with the COVID response, we sent out one email message and we had 13 healthcare provider entities sitting at the table to talk about setting up a community testing process and system. Next, looking at accountability and performance management. Overwhelmingly, the local health departments emphasized the opportunity that accreditation provided to pause and assess health department progress and identify areas for improvement. This quality improvement mindset helped local health departments quickly adapt, adjust, and improve during the pandemic. One local health department shared that they experienced leadership turnover during the response, and they were able to easily and quickly redirect because of their accreditation experience. The local health departments also noted that accreditation holds them accountable to high standards and rigor because of PHAB's requirements to report on performance management and their quality improvement or QI tasks. So having a gold standard for plans and general operations pushed local health departments to achieve quality standards and operate at a higher level. The local health department said that being accredited gives them a higher level of credibility and a good reputation among community members, partners, and policy members. The reaccredited local health departments also suggested that the initial accreditation provided the foundation for public health infrastructure and staff capacity, while reaccreditation offered an opportunity for further continuous improvement. The risk communications plans that local health departments established as part of the accreditation process supported their COVID-19 responses and provided a template for getting information out to people. These communication plans included best practices for communicating with the public, how to work with and respond to the media, and roles and responsibilities in the risk communication process, as well as lists of key contacts in the media and other individuals and organizations to communicate with daily during the response. And while COVID-19 really highlighted the importance of clear, coordinated communications, some local health departments indicated that the communications plan that they established during accreditation was maybe too general for the COVID-19 response, or didn't exactly provide the guidance they needed for vetting information and navigating the public mistrust and negativity. So ultimately, they made large adjustments to the plan during reaccreditation, including adding considerations for communicating via social media was one specific example. And these types of revisions to the plans developed during accreditation are an important opportunity for continuous quality improvement during reaccreditation. And then looking at organizational competencies and workforce development, the workforce development plans that were established during the accreditation process provided guidelines for staff roles and staff training during the response, including leadership, ethics, emergency preparedness, and incident command trainings. In some cases, the workforce development plan named specific staff who could step into leadership roles due to the scale of the response and provided a plan for ensuring those staff had the skills needed to assume those roles. Given the number of new or temporary staff that were recruited to support the response, just-in-time training enabled local health departments to recruit and onboard staff quickly. And the workforce development plans formalized the processes for training and onboarding these new or temporary staff. The COVID-19 response presented local health departments with new staff turnover and retention challenges, which underscored the need for workforce well-being support during an emergency. So after the response, local health departments identified several continuous quality improvement opportunities in this area, as the need to add considerations to their workforce development plans to address staff mental health and opportunities to boost staff morale during an emergency response. And consistently, local health departments contributed success during the COVID response to the persistence and innovation of their staff, really further highlighting the need for continued public health workforce development and support. So we heard from a reaccredited local health department who said, I think a lot of people that come to work in public health don't have degrees or experience in public health. I do think going through accreditation, there's an educational learning piece that benefits new or inexperienced employees. And then last but not least, looking at emergency preparedness and response, this foundational capability obviously supported the COVID-19 response. And local health departments also relied on the accreditation standards and measures specifically for emergency preparedness and response. So prior to accreditation and the pandemic, some local health departments already had robust emergency response systems. They received other emergency preparedness funding or participated in other emergency preparedness programs like CDC's Project Public Health Ready. For other local health departments, the Public Health Emergency Operations Plan that they developed as part of accreditation really provided a helpful framework for their incident command structure and training during the response. One accredited local health department you can see here said, if the pandemic happened prior to accreditation, I don't think we would have been able to respond as quickly as we did. So I'll wrap us up here with some discussion. First, to acknowledge the limitations of this particular study. It was qualitative in nature and based on the opinions of one or two staff from a limited number of local health departments. Findings from this subset of local health departments may not be generalizable to all health departments or all local health departments. However, we did aim to recruit a diverse mix of local health departments by size, rurality, and region. And since participating local health departments were accredited or reaccredited before the pandemic, so before 2020, some found it hard to discern what plans or processes were established as part of accreditation compared to other requirements or activities unrelated to accreditation, which potentially introduced some recall bias. To summarize our findings, the COVID-19 pandemic highlighted the critical importance of an established public health infrastructure rather than a temporary surge in funding or attention. Accreditation helped local health departments establish this infrastructure by operationalizing, formalizing, and improving their foundational public health capabilities, including partnerships, communications, organizational capacity, and workforce development, and accountability and performance management. The local health departments relied on the plans and infrastructure that they established during accreditation and reaccreditation to support their rapid response. And while these plans served as blueprints, local health departments were not fully prepared for the magnitude of the response, and many plans needed to be updated or adapted. And then lastly, the QI mindset that is encouraged by the accreditation and reaccreditation processes enabled the local health departments to quickly assess and improve throughout the response. And because of the real-time application of accreditation and reaccreditation during the response, local health departments did share that they are confident that they have the capabilities needed to respond to future emergencies. So public health accreditation really does serve as a framework and a foundation for local health departments' emergency preparedness and response, as we saw from the COVID-19 pandemic. The plans and processes established during accreditation bolstered local health departments' foundational public health capabilities, contributing to their ability to respond rapidly and efficiently during COVID. And then reaccreditation really offers an opportunity to build on the initial efforts established during accreditation, focus on that continued quality improvement, and apply lessons learned from the response. So thank you all so much. I do have my email address here if anyone would like to reach out or has questions following this session. But for now, I will pass it over to my colleague, Catherine Gelfand, to share about social return on investment of public health accreditation.
Thank you, Rachel. Hi, everyone. It's nice to be with you today. I'm Catherine Gelfand. I'm a Senior Research Associate at NORC, and I'm excited to talk about the SROI of accreditation. So we have no potential conflicts of interest to disclose, and this work was funded through PHAB and CDC. So again, similar to Rachel, a brief agenda here. I'll walk through some brief background on SROI, go over our methods, our findings, and then a short summary. So NORC conducted a study on the social return on investment of accreditation to help PHAB and health departments explain the costs, benefits, and impacts of accreditation to, the broader public health community and funders. Like Amy mentioned, this is a follow-up study to the work that the Health Policy Institute of Ohio did in Ohio. Like she mentioned, Ohio requires all of their local health departments to be accredited, so they're a unique kind of case study for this work. But the social return on investment is defined as the process of understanding, measuring, and reporting on the social, environmental, and economic value being created by an organization. So it really seeks to understand the broader impact of an investment beyond just the financial return. I'll quickly walk through our kind of objectives and methods here. So we had 4 main objectives, which were to identify the inputs, outputs, outcomes, and any broader impacts of public health accreditation, and also to try to understand the similarities and differences in the SROI between initial accreditation and reaccreditation. So we developed the semi-structured interview protocol in collaboration with PHAB and received approval from the NORC Institutional Review Board. The protocols were informed by the previous study conducted by the Health Policy Institute of Ohio, as well as existing PHAB surveys that are distributed to accredited health departments. We then selected the sample, which I'll get into a little more on the next slide. To recruit the health departments, PHAB sent an initial email to the director and accreditation coordinator, and the NORC team followed up as needed. We conducted 45-minute interviews over Teams and recorded and transcribed them. And then we conducted a rapid qualitative analysis focused on identifying and classifying interview excerpts as inputs, outputs, or outcomes. We use the PHAB domains as our guiding framework. And we also identified some themes on reasons for pursuing accreditation or reaccreditation. So some specific details on our sampling approach. First, we identified decentralized state and local health departments that had been accredited or reaccredited between 2022 and 2024. We selected these dates to be recent enough for staff to remember the accreditation process and also to be after the height of the COVID-19 pandemic. So this narrowed the list of eligible health departments to 55 accredited and 20 reaccredited. From this list, we then identified 9 in each group, trying to ensure a range of geographic regions, the size of the population served, and the number of health department FTEs. Ultimately, we were able to interview 9 accredited state and local health departments and 7 reaccredited state and locals. We had a few that kind of declined to participate or did not respond. These interviews were between March and May 2025, which was a bit of a chaotic time for the health department. So when we needed to, we identified kind of backup health departments within the sample to speak with. So getting into our findings a little bit, they're organized by reasons for pursuing accreditation, inputs, outputs, and outcomes. So I'll first talk about these reasons for pursuing accreditation. So both the accredited and reaccredited health departments reported applying for accreditation due to kind of motivated leadership interested in a designation. Accredited health departments also reported an interest in funding or additional opportunities that may result from accreditation. And we also heard a significant commitment to quality improvement as other reasons for pursuing accreditation. For reaccredited health departments, the reasons were slightly different. Their accredited status was a big source of pride and a really visible demonstration of their high quality services. So we frequently heard them say that they felt it was important to maintain that accreditation status for their community. Our interviewees also discussed some facilitators that contributed to their ability to successfully achieve accreditation or reaccreditation. Two that stood out were having staff champions, so individuals within the department that are strong supporters of accreditation that helped the momentum, help maintain momentum over the years. And then kind of strong leadership and staff engagement to encourage buy-in was another important facilitator. One accreditation coordinator noted that their director used kind of their knowledge of different staff strengths and skills to identify, good tasks for the different staff to engage in. We also heard a variety of challenges while pursuing accreditation and reaccreditation. Staffing and funding challenges was a common one. They noted that it was hard to obtain funding for accreditation due to siloed funding streams and federal grant requirements. Some partnership challenges. A few health departments reported challenges in working with partners in terms of kind of receiving data from local hospitals or gathering their documentation from external agencies when a PHAB requirement kind of fell out of the health department's purview. And then conflicting priorities. Health departments spoke about the lack of time to work on existing programs and projects. All the health departments that we interviewed began their accreditation or reaccreditation process during or soon after the COVID pandemic. So it was challenging for many to manage their accreditation workload as well as pandemic response. So getting into the inputs, in an SROI analysis, the inputs are what is contributed by individuals and organizations throughout the process. So we identified three main inputs, which are staff time and labor, engaging with partners, other governing entities and communities, and then procuring goods and services. So staff time and labor is definitely the most significant input for both accreditation and reaccreditation. They talked about the staff time and labor required to develop the plans, products, and procedures to complete the documentation for the PHAB standards and measures. We also heard, various experiences regarding the level of effort needed to do this, especially between different domains. The health departments use different approaches to staff the accreditation activities. Most health departments created teams or dedicated staff for specific domains, and a few kind of relied primarily on key individuals to manage the documentation. It also depended on the size of the health department. So a local health department that we spoke with that had 3 staff, kind of, it was a team effort across all 3 versus a larger health department of a few hundred had fewer folks working on it. We also heard that initial accreditation required more staff time and effort than reaccreditation. In the reaccreditation process, folks had more familiarity with processes and a better understanding of the expectations, so that contributed to the lower level of effort. Health departments also frequently discussed engaging partners, other governing entities in their communities, and community members as an input of accreditation or reaccreditation. We frequently heard that the health departments leverage their existing relationships. Some also created brand new partnerships. We heard about new coalitions or committees with external partners. And they definitely talked about the different types of partners engaged. So this table shows a few of the different partner types. So we heard about healthcare institutions being engaged with data sharing and supporting the community health assessment or health improvement plan. Universities were frequent partners for these as well, elected officials, community organizations, And we also heard about other health departments as well, being supportive in terms of sharing resources and lessons learned and just bouncing ideas off of each other throughout this accreditation process. The final input that we heard a lot was procuring goods and services. This was definitely reported less often than staff time and partners, but it was a frequent input and cost as well. We heard about contractors or consultants that provided technical assistance to support accreditation or reaccreditation. And health departments also reported investing in new software, things like performance management systems, smart sheets, things like that, that supported their specific domains. During the interviews, it was definitely a challenge for the health departments to think of the exact costs of accreditation, but one health department was able to share the costs required for them to achieve reaccreditation. So they mentioned all of these things, such as contracting with a local university, the workforce development plan, paying for a part-time accreditation specialist, the PHAB fees, and travel costs for strategic planning. This does not include the cost of staff salaries that also worked on accreditation. Okay, so the outputs of public health accreditation are the tangible, immediate, and intended results of the inputs. So in public health accreditation, these are the procedures, policies, and plans developed as described in the PHAB standards and measures. As we know that these outputs do not exist in silos or in they're written in individual domains, but they don't exist in silos. And they really help to strengthen the public health capabilities of the department as a whole. I think a great example of that is exactly what Rachel just talked about in her presentation, showing how all of the other foundational capabilities support agencies' emergency preparedness. So the next couple of slides just, show some of the key outputs for each of the 10 accreditation domains. So if you're less familiar, I can walk through these briefly. These are the first 5 domains, and the bullet points show some of the key outputs and documents that are created as part of accreditation. So things like the community or state health assessment, an emergency operations plan, communications campaigns, and community or state health improvement plans. And then the next slide just shows the last 5 PHAB domains and some additional outputs of accreditation. So things like, inspection or enforcement documentation, a workforce development plan, quality improvement plans. And then there's lots going on in the organizational infrastructure domain, like a strategic plan, information security, ethics. So all of those things really work together to strengthen the health department as a whole.
Hey, Catherine, really quickly, do you mind just maybe going off video really quick? You're a little garbled. Maybe that'll help.
Sure, yeah, sorry about that. Is this better?
It seems to be so far, yeah.
Okay. Thanks. So we frequently heard from newly accredited health departments that quality improvement processes were a really significant output of accreditation. Of the 9 that we spoke with, 7 highlighted quality improvement. So you can see in this table some of the things that they worked on as part of accreditation. So things like QI councils, customer satisfaction toolkits, monthly QI meetings. All of these things were frequently not activities that a health department had done prior to accreditation. So this accreditation process was really a helpful catalyst to start engaging in the QI efforts. Okay, so moving on to outcomes. The outcomes in an SROI analysis are defined as the short-term effects of an intervention's total set of outputs, and we identified 4 key ones. So increased staff knowledge and pride, increased use of data to inform decision-making, implementation of improved plans to enhance services to community, as well as strengthen relationships with external and community partners. So going through the accreditation process helps to increase staff knowledge and pride across the agency. One accredited health department shared that the processes and policies that were documented through accreditation help when they experience employee turnover, since new employees have a description of how the work should be done and what is expected. Other health departments noted that they have engaged in other kinds of knowledge sharing activities with other accredited health departments within their state and across the country. And when the health department, achieved their accreditation or reaccreditation status, there was a really big sense of pride among the staff for this, really, really significant accomplishment. Some of the interviewees we spoke with shared that their departments really made a concerted effort to make sure all staff knew about the updated plans, policies, and resources. And we heard about, celebrations that were thrown when they received the designation, local newspapers mentioning the accreditation status, just a lot of pride across the agency and within communities for achieving this recognition. I have a brief quote here that I'll read. So a reaccredited health department said, "We talked about how accreditation made the plan stronger moving forward and how input from staff was included in revising or creating these plans. I've had a lot of general feedback from staff who said that going through this process was really helpful for them and being able to quantify some of the work they do, collaborate with other co-leads from other domains, and learn more about where our resources can be combined in order to be more collaborative." The second outcome that we identified is this increased use of data to inform decision-making. One reaccredited health department shared that accreditation helped them rely on data-driven work throughout the COVID-19 response. They said they used GIS mapping to make immunizations accessible to everyone in their community, and with a special focus on individuals who may have experienced barriers in accessing vaccines. That's kind of what this quote is about, so I won't read it again. The third outcome of accreditation is really using these documents in their work to promote their community's health. So during the interviews, the health department directors and accreditation coordinators described how these documents are being used now. So this table shows a few examples. One health department talked about how their community health assessment has been presented to various partners, and their state health assessment data is available at the county level, so their local health departments are able to use it for their own assessments. Another reported their emergency operations plan helps staff feel more prepared, knowing that they have a process for identifying staff with different language capabilities and other, important skills in an emergency. The communications plan has helped a health department engage in more consistent communications branding. And developing a strategic plan offered an opportunity for a health department to create an internal quality improvement dashboard that tracks their progress towards their strategic plan goals. Another reaccredited health department said, "I think there's a lot more intentionality on promoting public health programming. And then also, I think we have improved more efficient processes for how some of the programs can happen and how we can facilitate those with partners." Speaking of community partners, the last outcome we identified was strengthen relationships with external and community partners. The interviewees we spoke with talked about establishing and maintaining trust in their communities, helping staff understand their roles and responsibilities, as well as their community needs better, which then contributes to the staff feeling better prepared to serve their communities. And finally, increasing the reach to vulnerable populations through consistent collaboration with community-based organizations and community leaders. While some health departments had strong pre-existing relationships with community partners, and found it difficult to kind of tease out the effect of accreditation on these relationships, others were able to tie their partnerships to accreditation. And I will share that on the next slide with a brief story that one health department shared. Yeah, so while, most of the outcomes shared were focused on internal changes within a health department or some relationship building, it was hard for most health departments to talk about the outcomes in their community or impacting health outcomes because of accreditation. But one health department did share this story about the impact of strengthened relationships due to accreditation. So this local health department conducted their first community health assessment as part of their accreditation requirements. And through that PHAB, they found one area in their community with a large unhoused population that needed additional services. So the health department then partnered with the community policing division of their police department, and they opened a satellite health department office in this area to provide additional services to this community. This was maybe 3 years ago. And since opening the satellite office, they've seen a 65% decrease in quality of life complaints in the area. And right before we spoke to this health department in about March of this year, when this health department learned that some of their federal funding would be cut, they announced to the community at a kind of community town hall event that they would have to close the satellite office as a result of these budget cuts. But the health department director shared how the community really rallied around the health department to ensure that funding remains for this satellite office. And during the town hall meeting, community members reported or mentioned how proud they are of this health department for being accredited, and that it really makes a difference to the community, and keeping this satellite office open was really important to them. So the local city was able to identify other funding to keep the satellite office open. So similar to Rachel's presentation, just a few limitations that are important to consider when interpreting the findings. This is self-reported qualitative data. We relied on the perspectives of just a few individuals at each health department, and their opinions may not reflect all attitudes related to accreditation, outcomes, and impacts across their whole agency. And we interviewed 16 health departments for this study, including only 4 states, which is a small percentage of the total number of accredited health departments. So while we did make an effort to identify health departments across geographic regions and sizes, it is, when you talk to one health department, you talk to one health department. For some of the health departments we interviewed, it had been over 2 years since they achieved their accreditation or reaccreditation status, so there may have been some recall bias. And then lastly, staff turnover. Occasionally, the health department director or accreditation coordinator that we spoke with was not employed by the health department at the time of their initial application, so they didn't have that kind of firsthand experience or knowledge of the process. Just a couple more slides, I'll walk through kind of our key takeaways. There were kind of 3, important themes that emerged. Having motivated leadership was a significant driving force for pursuing accreditation and reaccreditation. The most significant input by far was staff time and labor. And health departments were able to mainly identify internal outcomes of accreditation, and struggled to attribute broader impacts in the community to accreditation or reaccreditation. And lastly, this slide is just a summary of what I kind of walked through today in terms of the inputs, outputs, and outcomes of accreditation. And like Amy kind of showed earlier, the findings from the Ohio study, and we were able to we found fairly similar things to them. And I think, yeah, that's my last slide. My email is here as well. I'm happy to answer any questions, and Amy just put my email in the chat. So thank you all.
Hi, everyone. I'm Britt Lang, a Senior Research Specialist at PHAB, and I'm going to talk to you just briefly a little bit about some of the PHAB data that can be made available to you. All right, so accessing PHAB data. So like Amy mentioned, we have a lot of data that can be made available, and there are a couple of different ways to access different types of data. So we want to make sure that you're aware what's publicly available versus what would need to be requested. So if there's specific data that you're looking for, the first thing we're always going to recommend that you do is go to the accreditation activity webpage. So that's when you're on our website at the very top, it says accreditation and recognition. If you hover over that, then you'll be able to see accreditation activity. When you're on that page, where you see circled here, there's this Excel spreadsheet, and that Excel spreadsheet has a lot of the basic information that you might be interested in about accredited health departments. So it's going to have the name of the department, their state, health department type, accreditation dates, and the standards and measures version. So all of that is publicly available at all times. However, if you want data that goes beyond what's publicly available, then you're going to need to go over to our data and insights page and then go to request data to get the information that you're looking for to figure out what exactly it is that you need and what you want to request from us. So on that request data page, you're going to see our research agenda, so that can help you figure out and focus in on what questions you want to ask. You can look at our research and data use guidelines, our code book, which gets into the nitty-gritty of everything that we're able to make available, and then also our data request form. So of the data that we are able to provide, they kind of go into three buckets. The first bucket is taking what's publicly available, but just adding some additional variables. So on top of all those characteristics that I just talked about, it also would add in variables like population, jurisdiction type, budget, how many FTEs, kind of like additional demographic information. The next bucket of data that's available is information about health department performance as related to the accreditation process. So that's where you'd be able to get information on the scores that departments got on specific measures, information about ACARs, looking at narratives from reports from review, annual reports, readiness assessments, all of that sort of information related to scoring. And then the final bucket is going to be documentation. Generally, it's when I talk about documentation, I mention that most people who think they want documentation don't actually want documentation. It's a lot of work to comb through, often hundreds of pages of PDFs. Usually it's a lot easier to read the summary that comes from review of the documentation rather than having to go through it yourself. But if you do have a compelling reason to look at the documentation, that's absolutely something that we're willing to provide. And so if anything in those three buckets, if any of that is data that you're interested in looking at, the first step you're going to do is to complete that data request form and then email it to us at research@phabborg.org. We'll get back to you within 2 business days, and then we'll talk to you about any follow-up questions that we might have and to discuss things like scope, fees, timelines, and how we can get the data that you're looking for. The only exceptions to that is that if you are the CDC or if you're currently under contract with us. If you are in either of those categories, we're able to get data to you more directly. And then to talk a little bit more about some other data that's available and what we do with it. I believe it was Catherine that mentioned at one point that that we have these surveys that go out to health departments at different milestones in the accreditation and reaccreditation process. And those surveys that we put out are kind of a combination of asking sort of logistic questions, like asking, which of these resources did you use to prepare for accreditation? Or were you given enough time during the site visit that, kind of get into that real logistic stuff? And then we kind of have some more existential questions about how your department relates to the overall accreditation process. Like, have you seen an improvement in QI, in, different categories like that. So those are all questions that we ask during these 6 milestones. And so what we do with that data, we share that internally, all of that sort of logistics stuff. And then those bigger questions goes into our value and impact report. So that's something that we put together and goes out every July, that puts all the information together and kind of pulls out those tidbits that we think are the most interesting and compelling bits of our data for that past year. Feel free to use this QR code to look at that report right now, or otherwise, I believe it should be in the chat. And so that's where we're able to pull out a lot of these bigger stats about things like accountability, workforce, quality improvement, programs and services. Those kinds of nice shiny numbers that often are very helpful when sharing with constituents or governing bodies. So we always recommend that you look at that report. It's just a really great place to pull out some easy quotes instead of you having to kind of comb all over trying to find the information that you're looking for. And so we kind of think of this as a way of, there's that other data that's available to you and kind of requires a little bit more manual work to figure out what conclusions you want to come to, versus this value and impact report is there for you if you just kind of need to pluck some things out that would be helpful to share with your community. And so with that, I am going to pass things over to Amy to close us out.
Great. Thank you to all the presenters today. I just wanted to speak really quickly on how we use all of this information and how we use all of this data. So obviously a lot of the data that Britt just presented on our the self-assessments by health departments, data we use for quality improvement at PHAB. Britt shares that with our accreditation and recommendation team twice a year. And man, do they really go through it. And even in the middle of presenting it or coming up with ideas to change processes and things like that to make them better, to serve our customers. So that's number one. And then the second is related to this slide right here. We use it to update our standards and measures, as well as our reaccreditation process. We're in the process of updating both of those. And a lot of this information comes through. So for instance, in one of the presentations, it talked about how this impact evaluation showed how reaccreditation, the focus is really on quality improvement. We're like, that's where the gains were. And so we're like, yes. And that was a big part of how we reshape the reaccreditation process that we're doing some pilots on right now, that you'll hear more about next year. But this slide directly refers to our standards and measures updates. It was actually released last week, I believe, and it will close on December 31st. So we want the field's input on the revisions we're suggesting for standards and measures. So I think Sarah has put a link in the chat. That will take you to a page that has all sorts of information. It has an FAQ on there. It has the link to the survey itself, which is how we're gathering the information. It's also got some static documents where you can kind of work through before you do the survey. And we can, you may say, well, I only work in emergency preparedness at the health department. I don't want to, do all the domains. You can pick which domains and even exactly which standards you want to provide feedback on. So it's very flexible in that way. But we really want to hear from the field and make sure that all the information that we've heard over the past year, we've interpreted the right way in changing and making better our standards and measures. So really excited for that. With that, we so much appreciate you coming. I don't see any open questions right now, but again, after the webinar, we will send an email with the recording link as well as an evaluation. This was an evaluation webinar, so I hope you will take the evaluation, the importance of this data. So please do that. And also, if you have any general questions, again, that research@phabboard.org is a great place to start. But you've also got the two specific to NORC as well if you have any questions. But with that, thank you so much for attending today. And we hope we will see you again. Thanks.